Well, a warm welcome to today's talk, and this one really is an interesting story, but it's completely true. Now, it started here. So someone called Jimmy Dore, you'll probably know him if you live in the States, but he made a video about one of my videos, which is all very interesting. So here we have Jimmy Dore commenting on me about giving a correct administration technique for intramuscular vaccine. But it became interesting because Jimmy Dore posted this onto his Facebook. And Jimmy Dore's Facebook was fact-checked, as often happens with Facebook articles. And if you look at the Facebook article that was fact-checked, it takes you through to this link here. Now, again, I've posted the full links there, or you can click through from the site. So, study vaccines being administered incorrectly has been adjudicated as misleading. So that was the kind of headline. Now, this, remember, is talking about Jimmy Dore's video about my video. But when you actually look at this, it's actually a very nice piece of work. So I was quite delighted to get this extensive peer review, which is great because, of course, we're always open to peer review as long as it's objective. And this was. So really quite an interesting turn of events, and some new facts have come up with it as well, it has to be said. So here we are, fact checked by Facebook. Check all the links for yourself, it's all there. So this was a video about my video about this paper. So in other words, it was about this paper here. Now, this is the paper in question. We looked at it a few days ago, and it's about giving intravenous injections by mistake that could cause acute myopericarditis in mice. And we looked at this quite extensively and talked about it at the time, and many of you have watched, and a lot of you have commented, of course, on that, which is always great. Now, this basically was saying that if you give mice the vaccine, if you give them the mRNA vaccine and you give it intramuscularly, they're fine. They don't get inflammatory heart disease. If you give it intravenously, they do get inflammatory heart disease. Therefore, the implications for aspirating when you've stuck the needle in and drawing back are really quite strong from this article, and that's what we looked at. Now, this fact-checking thing here really is quite interesting. So there was two main academics involved in the feedback here, and we're going to look at both of them. We'll look at Leo Nicolai first. Now, Leo Nicolai is a cardiology fellow, and is at a university in Munich, Maximilian University of Munich. Now, this is the German Centre for Cardiovascular Research, so this is pretty prestigious stuff. Now, a cardiology fellow, at least if it was in the UK, this would be a cardiologist who is doing some specialised research. So this is proper, fairly high-level stuff that we're talking about. And he says this about the paper and about my... So what we're moving on to now is really my video rather than Jimmy Dore's interpretation of my video. But I will be sending all these individuals links for this, of course. So Dr. Leo Nicolai says this: indeed, there is peer-reviewed work showing in mice that possible intravenous injection of mRNA vaccine leads to myocardial inflammation. So he's agreeing with me, which is interesting. And this guy's a research cardiologist. So, this is remarkably reassuring to see that people of this calibre are agreeing with me. And he goes on that intravenous injection of adenovirus vector-based vaccines. Now, here he's talking about the adenovirus vector-based vaccines, which, of course, the Oxford AstraZeneca and the Janssen Johnson & Johnson. But we'll come on. But the first article that we looked at was about the mRNA vaccine. So this seems to apply to both vaccines, and he does reference both of them in his piece. Offering a possible explanation for vaccine-induced thrombosis, thrombocytopenia. So here he's saying that intravenous injection of the vaccine could give rise to the side effect that we've been worried about. These data might indicate a simple measure to lower the incidence of vaccine-induced side effects. And we agree with Dr. Nicolai 100% here. What we need to do is draw back, and we eradicate the possibility of, no matter how small, of inadvertent intravascular administration. So by being fact-checked, I've been massively supported here. So I'm really quite buoyed up by this, as you might gather. Of course, whether I'm right or wrong is irrelevant. What matters is we change practice and stop this side effect from happening. He says there's a lack of data on the frequency and effects of intravenous injections in humans as a proviso. Now, this is of course true. Now, what we could do is we could get say let's say 5,000. Make it 2,000. 2,000 should do. Get 2,000 humans. Give 1,000 the vaccine intramuscularly and make sure it goes intramuscularly by aspirating. And rather than giving it into the muscle in another 1,000 humans, just roll up the sleeve and give it straight into a vein, an intravenous injection. Now, of course, that would never happen. It's completely, utterly unethical. That was a joke. So obviously we can't do this. So what is said here really, there's a lack of data, a frequency of effects of intravenous injections in humans. Obviously there is, because we can't do it. And we don't even know that in intramuscular injection, when you stick the needle in, how many times it goes into a vein. I estimate once in about 3,000 to 4,000. One injection in 3,000 to 6,000 is my estimate, but that's not based on firm data. But of course, you stick it in. Now, if that end tip there does happen to be in a vein, of course, you would never know about it because it just squirts in and you don't see it. So by definition, we don't know this. This is the problem. This is why people are getting it wrong, in my view. So he says most likely two approaches are needed to further vindicate the data. So he's saying that this is correct, but we just need to vindicate it, or he's intimating that it's correct. It needs vindicated. Large animal studies, of course. Simple comparison incidence of vaccine-associated thrombosis, thrombocytopenia, myocarditis in countries with mandated syringe aspiration to countries that don't mandate this practice. But the trouble is, the vaccines, this type of vaccine is not used very much in the only country I know of that mandates this practice. Although China and Thailand do seem, from the videos I've seen, China and Thailand do seem to be getting this right quite extensively. Russia, I don't know. But all the videos I've seen from the UK and America were not aspirating. In my view, we are giving this wrongly. So we agree, but of course that's a fairly obvious way to compare it. Indeed, I would estimate that over 1,000 of you on your comments have suggested that. Now, this is also Leo Nicolai's latest paper. So he himself is an author here. And this is his paper that he's just published with his team here. So here we see the name here, lots of other authors. Now, to be fair, this is a preprint, not yet peer-reviewed, only came out on the 29th of June 2021. But I've read this paper and it looks pretty good. So I think Leo Nicolai and his team have done a good job on this paper. But let's look at what he's saying in this paper. So this paper here is thrombocytopenia and splenic platelet-directed immune response after intravenous Oxford vaccine administration. So remember, this is if it's intravenous, and it's not supposed to be, but because of our bad technique in the UK and the US, sometimes it is given intravenously. So this is what Dr. Nicolai is saying on his paper. Recently, a rare and novel complication of SARS coronavirus 2 targeted adenovirus vaccine has emerged, thrombosis, thrombocytopenia syndrome. We know that. And we know that thrombosis is blood clots in the vessels. And thrombocytopenia is a lack of thrombocytes, and the thrombocytes are the platelets. And the platelets all clot together and they form blood clots. But all the platelets are used up, and that therefore the blood's more likely to bleed as well. So you get this paradoxical situation where you get blood clots in unusual parts of the body, such as the sinus veins draining the brain. But you also get a deficiency in the clotting factors as well, because you use your platelets up. Now, they employed an in vitro and in vivo model, so in life and in theoretical studies, to characterise the possible mechanisms of this platelet-targeted immunity. So they're working on how this platelet-targeted immunity works, and this is pretty advanced stuff. This was not well understood at all up until really quite recently. We show that intravenous but not intramuscular injection of Oxford vaccine triggers platelet adenovirus aggregation, formation and platelet activation. Now, this is in mice because, of course, as we've said, we can't do it in humans. But just take a minute to look at what he said there. This is a powerful statement. We show that intravenous but not intramuscular injection of Oxford vaccine triggers the thrombocytopenia thrombosis. And we can eliminate the possibility of giving it intravenously by sticking the needle in and simply drawing back. Why don't we do it? So this is massive support for the hypothesis that we've been talking about for some time. Intravenous but not intramuscular injection causes the problem. It's these inadvertent intravenous injections which could be a big, big factor here. It goes on, after intravenous injection, these aggregates are phagocytized by macrophages in the spleen, and platelet remnants are found in the spleen. Now, I'm not going to go into this in detail, but what he's saying here is if this is given intravenously, then what happens is that the pieces of vaccine here that are given, then they form they form lumps with the platelets. So there's the platelets there. So that would be the platelets, and these would be the adenovirus vector vaccines here, and they form big clumps like that. So they form clumps. And of course, that's using up the platelets and it's clumping the platelets together. But then what it's saying, the special cells that eat, called phagocytes in the spleen, actually eat this lot because it's not supposed to be there. They digest it. So that's what that is saying. So these aggregates are phagocytosed. Phago is to eat, cell cytosed. So they're eaten by cells called macrophages. Big phages eat, big eaters in the spleen. And platelet remnants are found in the spleen, and they specify the anatomical locations in the spleen. This is followed by a pronounced B-cell response with the emergence of circulating antibodies binding to platelets. So not only do we use platelets here, this causes the antibodies, the anti-platelet antibodies to be produced, and these anti-platelet antibodies will clump together all the platelets like that. And if you clump together all the platelets, that means there's no platelets left in the blood, or very few platelets left in the blood to cause proper blood coagulation, but all the platelets are clumping together and therefore they are forming a clot. And once you actually get the platelets there like that, you actually start getting proper blood clot forming over the top of it as well, because the platelets trigger this proper blood clotting process. So it all makes perfect sense, and they've elucidated that mechanism really quite cleverly, it has to be said. So they say our work contributes to the understanding of thrombosis, thrombocytopenia syndrome, and highlights accidental intravenous injection as a possible mechanism for post-vaccination thrombocytopenia, thrombosis. And again, I really can't emphasize this strongly enough. Let me read, this is a direct quote. Our work contributes to the understanding of TSS and highlights accidental intravenous injection as possible mechanisms for post-vaccine thrombosis, thrombocytopenia syndrome. I now consider it to be completely unethical that our governing bodies do not advise all of our vaccinators to take precautions against inadvertent intravascular intravenous administration. This has crossed over from ignorance into negligence if they don't act on this pretty soon. And I'm not going to show you my letter from Nadeem Tahar with the vaccine minister again. I've showed you that twice already. You know, I've already reported this to ministerial level and nothing has been done. But let's carry on. Hence, safe intramuscular injection with aspiration prior to injection. And he's a scientist, so he's being modest. Could be a potential preventing measure when administering adenovirus-based vaccines. So this is true with the adenovirus-based vaccines, but we have just looked at this other paper here that we looked at first, where it was true with the side effects which are caused by the mRNA vaccines as well. So this is applying to thrombocytopenia. This is applying to myocarditis. And these two complications alone, as well as being very damaging to people's lives, have done more to damage the vaccination programme than anything else because of these rare side effects. Now, going on to the second academic concern in this rather interesting fact-checked here thing that we are looking at. The second academic here is Helen Pertussis-Harris, Associate Professor, University of Auckland. So let's see what Professor Pertussis-Harris is saying about this. Again, she's a vaccinologist, knows what she's talking about, Associate Professor, University of Auckland. There are a range of injection techniques for administering vaccine, she says. Injecting fast, withdrawing the needle. Injecting slowly before withdrawing. Now, I would be in between these two. I wouldn't give it fast because you can damage the tissues. I wouldn't give it too slowly because it can cause pain. So I'd be in between those two. Third way, she says, pulling back on the plunger, seeing if there's no blood, then injecting. This is called aspiration, and we'll demonstrate it again at the end of this video. Rationale for aspirating, according to Professor Helen Pertussis-Harris. Vaccines could be inadvertently delivered into the blood rather than into the muscle tissue. I agree, Professor. But as the flashback of blood hardly ever happens, the practice was abandoned by many practitioners. That's right, it hardly ever happens. I've seen it, I can only remember seeing this once in my 40-year career, maybe twice. But I've talked to others of you who've seen it as many as 1 in 30 times, others who've just seen it again once or twice in their careers. But it doesn't matter. All we need is 1 in about 10,000 or 20,000 or 30,000, and we've got a big problem with the vaccination programme. So that is no excuse, because it doesn't happen very often. Look, come on this aeroplane with me. I hardly ever crash. Tell you what, do you want to come for a ride with me on the back of my motorbike? I hardly ever fall off it. I hardly ever drive into cars. Very, very rarely. Of course you wouldn't. The fact that it hardly ever happens is irrelevant. It does happen. Let me be clear. This does happen. It does happen. But Professor Helen Pertussis-Harris goes on to say this, and this really is quite powerful. She says, I've not seen any evidence to support the rejection of this hypothesis at this stage. So in other words, she's not disagreeing. She's not seen any evidence to support the rejection of the idea that inadvertent intravascular administration causes the problems. So we agree. The animal model study supports the possibility that inadvertent injections into a blood vessel could result in undesirable reactions. We agree. However, the majority of myocarditis cases occur in young males after the second dose, something that is not explained by this hypothesis. I agree, but let me explain that. And we did do this at the time. If people had actually watched my video, I wouldn't need to say this twice. But so, yes, this is happening predominantly in young males, but no one is saying that no one is saying that inadvertent intravascular administration is the only possible cause of this. We're saying it's one possible factor. So old people like me might get an intramuscular injection. It might go into a vessel inadvertently, but I might not get the side effects because of other factors that are associated with age. So is there some factor associated with being young and male, or even being young and female to a lesser extent, plus the effect of the inadvertent intravascular administration? Because there could be several factors, like 3 or 4 factors here that have to line up. This is kind of the Swiss cheese model, isn't it? They all need to line up. So this is actually, Professor, if she's thought about it, I'm sure is no objection at all. Because we're not saying this is the only explanation. There's probably several factors have to line up. But if we eliminate the variable of intravascular administration, the fact that some of the other factors line up, like being young and male, would become irrelevant. Because we're not giving it into a vessel. It would become irrelevant. And of course, many of you, hundreds of you did point that out in various comments. But Professor Pertussis-Harris concludes that this requires more research and observation. The patterns of post-vaccine myocarditis among populations where aspiration is practiced could be helpful, of course, but because that's not done very often. But we could, an obvious study here would be in Thailand, where they seem to do it properly, would be a cross-cultural study with Thailand, which would be good. Now, just to conclude, last thing I want to say, this is from here. Now, this is from the Serum Institute of Denmark, and they do advise correct technique. So very impressed with Denmark here, because they are much more up to speed on this than we are. It's actually under doses and administration. Based on a precautionary principle, we recommend aspiration before injection, is what they're saying here. But just to clarify that, common sense in Denmark, delighted to see. Serum State Institute of Denmark. This has gone in circulars to all nurses and doctors in Denmark, so they all know about this. COVID-19 Janssen vaccine. Now, this is talking about this one particularly, but it does apply to the other vaccines in Denmark as well. They point out on this particular thing, that this particular reference we're using here, they point out that a single dose of 0.5 mils dose undiluted vaccine is given. So it's undiluted. We don't want undiluted vaccine going straight into the blood. Based on a precautionary principle, we recommend aspiration before injection, of course. We agree completely. Now, the authorities in the United States and the United Kingdom that are currently not giving this correct advice, in my view, they would be remarkably embarrassed by this, of course. They're not going to stand up and say, oh, we got it wrong all this time, we'll need to start vaccinating. But they could say something like, we need to start vaccinating correctly by aspiration. But they could hedge the bets and say something like, I don't know, something like, out of an abundance of caution, we think it's probably a good idea to do this, or something like that. You know the way they talk about these things. Now I'm going to demonstrate this one more time. So here we have our blood vessel. Now here we have our syringe. So you stick that into the muscle, and if you draw back and you're in muscle, then nothing is going to come out because there's no blood going directly through the muscle cells themselves. But if inadvertently the tip of your needle, the tip of the vaccinator's needle, which you can probably just about see there, if that inadvertently goes into a blood vessel, when you draw back, it becomes immediately obvious because you see the blood coming in. Therefore, you know not to give it into a blood vessel. It is that simple, and it is not being done, and it is inexcusable. So that's another paper with even more evidence. How much more do we like? But it just really, I thought that was a really good story, that this was actually discovered through a video about one of my videos being flagged up as misleading, or whatever the term was, but actually massively substantiating what we have been postulating for some time now. So certainly when I go for a vaccination, I'm going to insist that the vaccinator aspirates, so I'm not going to get it. You know, we need to aspirate before we vaccinate. That rhymes, doesn't it? Aspirate before vaccinate. Aspirate before vaccinate. Aspirate before vaccinate. Are you listening? All these authorities, all these clever people. Aspirate before vaccinate. Thank you for watching.